Welcome to Deep Dive Ortho, the show dedicated to extracting the most vital insights for orthopedic professionals like you. Today, we're really delving into an area of wrist trauma that often flies under the radar but carries significant long-term implications. Trapezium fractures. It's a small bone, yet absolutely crucial for intricate hand function, and its fractures frequently pose real diagnostic and management challenges. Joining me to explore this fascinating topic is Professor Mo Imam, an expert in orthopedic surgery known for his ability to synthesize complex clinical data and illuminate the pathways to optimal patient care. Our goal today is to truly arm you with a comprehensive understanding of these uncommon yet important injuries, from their subtle presentation to advanced treatment strategies and the critical role of rehabilitation. So let's get stuck in. Professor, for our audience, let's begin with the fundamentals. Where exactly is the trapezium located, and what makes it such a linchpin in wrist and thumb mechanics?
Right. Well, what's truly fascinating here is how such a small bone holds such pivotal importance for overall hand function. The trapezium, which is also known as the greater multangular bone, is one of the 8 carpal bones. It's uniquely positioned right at the base of the thumb, essentially forming the critical foundation for thumb movement. Its defining characteristic, and what makes it so special, is its distinct saddle-shaped inferior surface. That shape is key. This surface articulates perfectly with the base of the first metacarpal, creating what we call the carpometacarpal, or CMC, joint to the thumb.
The CMC joint, right. And that saddle shape is what gives the thumb its unique movement.
Precisely. This particular saddle joint is the anatomical marvel that grants the thumb its extraordinary range of motion. Think about it. It allows for flexion, extension, abduction, adduction, circumduction, and, most crucially, opposition. Opposition is that unique ability for the thumb to touch each of the other fingers.
Enabling tasks like pinching, gripping.
Exactly. Gripping, manipulating small objects. This is absolutely fundamental for so many daily activities, from picking up a coin to writing. It's vital. And beyond this key articulation, the trapezium also articulates superiorly with the scaphoid and medially with the trapezoid and the base of the second metacarpal. It truly sits at a critical anatomical crossroads within the wrist, integrating multiple force vectors and movements. It's quite complex.
And it's not just the bone itself, is it? The ligaments play a huge role, too.
Oh, absolutely. Beyond its bony articulations, the trapezium relies on a complex network of ligaments for its stability. And this is just as vital as the bone itself. The anterior oblique, often referred to as the volar beak, ligament is particularly noteworthy. It acts as a primary static restraint against CMC joint subluxation. It originates from the palmar tubercle of the trapezium and is crucial for preventing the thumb metacarpal from slipping out of place, forwardly.
I see. And dorsally.
Yes. We also have the dorsiradial ligament, which is considered the strongest and primary restraint to dorsal dislocation. It works alongside posterior oblique and intermetacarpal ligaments. These ligaments are essentially the guy wires that keep the joint congruent and stable under load. Think of them that way. Furthermore, various muscles attach to the trapezium, including the opponent's pollicis and flexor pollicis brevis, both vital for thumb movement and precise control. And the flexor carpi radialis tendon even runs in a distinct groove on its palmar surface, acting as a dynamic stabilizer. This intricate arrangement of bones, ligaments, and tendons allows the trapezium to facilitate powerful gripping, pinching, and other force-applying tasks that are absolutely essential for daily function and ultimately a patient's quality of life.
It really is incredible.
Losing any aspect of this integrated system can be profoundly debilitating.
That's an incredible amount of activity and complexity for such a relatively small bone. Given its central role and the intricate mechanics you've described, how well is it actually equipped to handle the substantial forces it endures in daily life?
That's a very good question, and it's a fascinating aspect of the trapezium's anatomy. Despite the substantial forces it endures, the trapezium actually boasts an excellent blood supply. This supply is provided by multiple branches from the radial artery, which directly supply its palmar, posterior, and lateral surfaces. In addition, recurrent radial artery branches contribute further to the palmar surface. Crucially, these systems feature multiple interosseous anastomoses, effectively a rich network of interconnections within the bone itself.
So unlike the scaphoid, for example.
Exactly. What this means clinically is that the trapezium is considered a very rare site for non-union. This is a stark and welcome contrast to conditions we sometimes see, for instance, with scaphoid fractures, which often have a more precarious, single osseous vessel supply, making them notoriously prone to non-union and prolonged healing. So from a vascularity standpoint, the trapezium is quite resilient.
But biomechanically, it's under a lot of stress.
Yes. While its vascularity is robust, the biomechanical forces it experiences are indeed substantial, and this is where its vulnerability lies. Imagine the daily grind on that tiny trapezium. Studies have indicated that during tasks requiring powerful grasp and forceful pinch, simple actions like opening a jar, turning a key, or using a screwdriver, the joint reactive force at the base of the thumb, specifically at the CMC joint, can be up to 12 times greater than that generated at the tip of the thumb during a simple lateral pinch.
12 times. That's astonishing.
It is. That is an astonishing amount of load concentrated on a small articulating surface. Furthermore, the scaphotrapezium joint also experiences significant forces during gripping. This consistently high-load environment explains precisely why accurate diagnosis and meticulous treatment of trapezium fractures are paramount. Any compromise to the articular congruence, even a subtle step-off or instability within this joint complex, can lead directly to long-term joint integrity issues, potentially culminating in debilitating post-traumatic osteoarthritis, significantly impacting a patient's ability to perform everyday tasks pain-free.
Which really underscores the need to get the diagnosis right first time. That certainly puts into perspective the incredible stresses this small bone endures and why precise management is so critical. So, with that understanding of its vulnerability, how do these injuries typically manifest? What should clinicians be on the lookout for in that crucial initial assessment in the emergency department?
Okay, well, there are two primary mechanisms of injury that typically lead to trapezium fractures and associated thumb CMC dislocations. Firstly, and quite commonly, we see indirect axial overload. This often results from a fall onto an outstretched hand, the classic FU injury. In this specific scenario where the wrist is forced into hyperextension and radial deviation, the trapezium gets severely compressed or sort of squashed between the base of the first metacarpal and the radial styloid. Yes, this crushing force frequently results in a shear fracture through the radial side of the trapezium body and can simultaneously injure the critical CMC ligaments, leading to significant joint instability. Secondly, direct dorsoradial impaction can also cause these fractures, perhaps from a direct blow to the thumb base.
And ridge fractures, are they different?
Yes, when we consider trapezial ridge fractures, specifically that small projection on the palmar aspect, these may result from a direct blow to the base of the ridge itself or, importantly, an avulsion of the transverse carpal ligament from the tip of the ridge. This often occurs with direct trauma to the thenar eminence. The presentation can be very subtle, sometimes just an achy pain, which unfortunately contributes to a high rate of initial misdiagnosis.
And why is the diagnosis so challenging? You mentioned subtlety.
Well, the challenge in diagnosing these injuries stems from their relative rarity. They account for only 1 to 5% of all carpal fractures, even though they are, interestingly, the third most common carpal fracture overall. This infrequent encounter can make them notoriously difficult to detect, and consequently, they are easily missed on standard radiographs.
So standard x-rays often look normal.
They can, yes. Clinically, patients often present with pain and swelling around the first carpometacarpal region, or indeed the anatomical snuff box. However, as I mentioned, the presentation can be quite subtle, sometimes described simply as a diffuse achy pain, perhaps exacerbated by thumb motion, without obvious deformity or significant swelling. This subtlety frequently leads to a high rate of misdiagnosis. In fact, one study highlighted that an alarming 84% of patients ultimately diagnosed with a trapezium fracture were initially suspected to have a scaphoid fracture.
84%, that's a staggering figure. What specifically, in your experience, leads to that high rate of misdiagnosis? Is it just the anatomical snuff box presentation or something else that consistently throws clinicians off, especially compared to the more commonly suspected scaphoid fracture?
That high rate is indeed a significant concern, and it largely comes down to a few factors. Firstly, yes, the anatomical snuff box tenderness is a classic sign of scaphoid fracture, and trapezium fractures can present with similar pain patterns. So that leads to a natural bias towards the more common diagnosis. Clinicians are understandably primed to look for scaphoid injuries first. Secondly, the subtle nature of the injury itself plays a huge role. Unlike a dramatic wrist deformity, a trapezium fracture might only cause a diffuse ache, sometimes aggravated by pinching or gripping. This might lead a patient to delay seeking care or for an initial examiner to dismiss it as a sprain.
And the x-rays themselves.
Thirdly, and critically, the standard radiographic views often simply don't adequately visualize the trapezium. Its complex, overlapping anatomy means a fracture can be completely hidden. A patient might have pain, their x-rays are reported as normal, and they're discharged with a diagnosis of a wrist sprain, only to return months later with chronic pain and developing osteoarthritis.
A common scenario, unfortunately.
It is. The key takeaway for practitioners, therefore, is to maintain an exceptionally high index of suspicion, particularly when faced with a mechanism of injury involving axial loading or direct trauma to the base of the thumb. Even if initial plain films appear unremarkable, never rely solely on routine X-rays when the clinical picture suggests something more. You have to think beyond the initial films.
Given these diagnostic challenges and the high rate of missed injuries, what specific imaging protocols should be followed to ensure we get a correct and definitive diagnosis from the outset?
Right. For initial assessment, we always recommend orthogonal radiographs of the wrist. This would typically include standard PA, pronated AP, and lateral views. However, as we've discussed, the unique anatomy of the trapezium means these standard views are often insufficient. Crucially, specific projections are frequently necessary to clearly separate the trapezium's outline from the surrounding carpal bony complex and truly visualize the fracture.
Like which views specifically?
This includes specialized views like the BET view, which provides an oblique view of the trapezium, and a lateral radial ulnar radiograph taken in 10 to 30 degrees of supination designed to unmask the bone. These additional projections can significantly improve visibility and unmask subtle fractures that would otherwise be missed. Yet even with these targeted views, conventional X-rays frequently miss undisplaced fractures, especially those oriented sagittally or through the body. It remains a challenge.
So if X-rays are inconclusive, what's the next step?
CT. Absolutely. This brings us to the absolute importance of cross-sectional imaging. If plain radiographs are not conclusive, or if there's a high clinical suspicion of a carpal fracture despite seemingly negative X-rays, perhaps due to that axial loading mechanism or persistent localized pain, a computed tomography or CT scan should absolutely be performed. CT is invaluable not just for definitive diagnosis, but also for meticulous preoperative planning. It allows us to precisely delineate the size and degree of displacement of fracture fragments and, critically, to accurately assess articular involvement, which is paramount for long-term outcomes and guiding surgical strategy.
It really gives you that detailed picture.
Exactly. For example, numerous case series have detailed instances where trapezium fractures were only identified on CT after initial X-rays were negative or inconclusive, highlighting its superior sensitivity in picking up subtle cortical breaks or trabecular disruption. You can show the exact orientation of the fracture line, the amount of comminution, and any intra-articular step-offs with millimeter precision. It's incredibly helpful.
And what about MRI? Does that have a role?
While magnetic resonance imaging, or MRI, isn't typically required for acute fracture diagnosis, it can be useful for identifying truly occult fractures that even CT might miss. Or, perhaps more importantly, associated ligamentous injuries, especially to the crucial anterior oblique ligament or dorsal-radial ligament, which plain films and even CT might not fully delineate. It's also worth noting that no single modality, whether it's MRI, CT, or bone scintigraphy, is 100% accurate for diagnosing occult scaphoid fractures, and it's highly likely that these results also apply to diagnosing the less common trapezium fractures.
So none are perfect. What about follow-up? Do we need repeat scans?
Well, this leads to a clinical dilemma regarding follow-up imaging, particularly for assessing fracture consolidation. X-rays, as we know, have limited value for assessing the healing of these particular fractures due to the bone's complex shape and overlying structures. Therefore, if clinical examination demonstrates no pain, excellent range of motion, and good restored function, a routine follow-up CT to confirm bony union may not be necessary. It's about striking a sensible balance between diagnostic certainty, cost implications, and limiting unnecessary radiation exposure to the patient. It truly comes down to integrating clinical assessment with imaging findings.
So, Professor, once a trapezium fracture is definitively diagnosed, often after that careful imaging, how do we then classify it? And perhaps more importantly, what does that classification tell us about the injury itself and its implications?
Right. Classification is key for guiding treatment. Once we have that definitive diagnosis, the Walker classification system is our go-to for categorizing trapezium fractures. This system divides them into 5 main patterns, and understanding these is absolutely crucial for guiding treatment decisions and anticipating potential complications.
Can you run us through those types?
Certainly. These patterns include type I, which is a horizontal sagittal split. This is often a relatively stable fracture running across the bone in the sagittal plane. Then there's type 3, a medial distal avulsion, and type II, a medial proximal avulsion. Both involve a fragment pulled off from the medial side, usually involving ligament attachments. Type 3 is a lateral distal avulsion, a fragment pulled off the lateral side. Type 3 is a vertical sagittal split. Now, this is the most common pattern and often results from direct axial compression, where the force splits the bone vertically. These can be more unstable and often intra-articular.
And the most severe.
And finally, type V, comminuted fractures. These usually stem from high-energy trauma, resulting in multiple fragments and significant articular disruption. Highly complex. In broader terms, we also categorize them simply into ridge fractures, involving that palmar projection, and body fractures, which involve the main substance of the bone.
And understanding these helps guide treatment.
Absolutely. Appreciating these distinct patterns allows us to grasp the specific complexity and implications of each injury. For instance, a comminuted body fracture, type V, will have a vastly different prognosis and treatment plan than a simple horizontal split, type I. The classification isn't just academic, it directly influences our clinical decision-making regarding conservative versus operative management and the specific surgical technique chosen.
That clear breakdown of the classification is invaluable. But are these fractures typically isolated events, or do they often present with other injuries within the wrist?
This is a critical point for orthopedic professionals, and it's where the nuance of trapezium fractures truly comes into play. You see, isolated trapezium fractures are in fact quite rare. They account for only about 20% of cases in many series. More often than not, they are accompanied by other significant injuries in the hand or wrist.
Says.
These can include classic injuries like Rolando's or Bennett's, fractured dislocations of the thumb metacarpal, scaphoid fractures, as we discussed, often confused with or occurring alongside trapezium injuries, and very frequently a dislocation of the first carpal metacarpal, or CMC, joint. This common association highlights that the forces causing these injuries are rarely confined to just the trapezium. They usually involve broader energetic trauma to the carpus.
You mentioned a ring bone model. Tell us more about that.
Yes, what's fascinating here, and truly a potential game changer for our diagnostic approach, is a recent study that proposes a ring bone model for wrist injuries. Think of it like the pelvic ring. If you have a fracture on one side of the pelvis, you instinctively look for a second injury, perhaps a contralateral fracture or a ligamentous disruption, because the ring structure itself has been compromised.
Okay, applying that to the wrist.
The ring bone model applies the same crucial principle to the carpus. It suggests that the carpal canal and the overlying transverse carpal ligament function as a closed ring. The implication is that when this ring structure is disrupted, injuries can occur on opposing sides. It makes intuitive sense when you think about the anatomy. This ring bone model helps to explain precisely why trapezium fractures, particularly body fractures, are so often associated with other carpal injuries. The study I mentioned revealed a higher incidence of trapezium fractures than previously reported in the literature, which is significant in itself. But crucially, it found that 62.5% of the trapezium fractures identified were associated with Bennett fractures, the classic intra-articular fracture of the base of the first metacarpal.
Over 60%.
Yes, and perhaps even more strikingly, 50% were associated with previously unreported ulnar-sided carpal fractures, such as hamate or triqueter body fractures. This frequency of ulnar-sided injuries was nearly equal to that of concomitant Bennett fractures in their series. That's a really important finding.
Professor, that ring bone model is truly a revelation for our diagnostic approach. What's the absolute non-negotiable takeaway from that for every clinician listening right now? What's the core implication we need to internalize?
Right. The critical takeaway is this. A trapezium fracture is rarely an isolated incident. If you identify one, you must have an exceptionally high index of suspicion and perform a thorough evaluation for associated injuries on the ulnar side of the carpus, and certainly for metacarpal base injuries.
So don't just stop at the trapezium.
Absolutely not. You cannot stop looking once you've found the trapezium fracture. Missing those associated injuries will unequivocally lead to persistent pain, ongoing instability, and poor long-term outcomes for the patient, even if the trapezium fracture itself is adequately treated. Think of it as a potential bilateral injury within the ring, or a ring disruption. Even if the initial presentation only highlights one side, it fundamentally shifts our diagnostic paradigm from isolated injury to a regional ring disruption. I've personally seen cases where a patient presented with chronic pain after what was thought to be a simple trapezium fracture, only for a later, more comprehensive scan to reveal a subtle, ununited hamate fracture that was the true ongoing source of their debilitation.
A cautionary tale.
Indeed. This ring bone concept really reinforces the need for a comprehensive assessment of the entire carpus. Look wider.
So, Professor, we've navigated the tricky diagnosis and classification of these elusive fractures, and now we understand the profound importance of looking beyond just the trapezium itself. For the orthopedic professional sitting across from a patient with a confirmed trapezium injury, the most pressing question emerges. What's the optimal path forward? Do we reach for a cast, or is surgical intervention the immediate call? Let's delve into the nuances of conservative versus operative management.
Absolutely. This is where the art and science of orthopedics really come together. For non-displaced body fractures and acute trapezial ridge fractures, non-operative treatment primarily involves immobilization. This is typically achieved with a thumb spica cast applied for a period of 4 to 6 weeks. This specific type of cast provides rigid, constant support to the thumb and wrist, which is crucial for stable fractures to heal without displacement.
So immobilization is key for those stable types.
Yes, it prevents rotation and axial loading of the joint, allowing for undisturbed bony union. For subacute trapezial ridge fractures, where the CMC joint is clinically stable and not prone to subluxation, observation might even be considered, though this is less common. Now, while some older reports describe successful conservative treatment with plaster casts for non-displaced fractures, it's also important to acknowledge that others, particularly for comminuted fractures or those with any degree of displacement, have shown rather dismal results with this conservative approach.
So it's not always successful.
No, it clearly indicates that the success of conservative management is highly dependent on the precise fracture pattern and, critically, its inherent stability. Displaced or comminuted ones often don't do well without surgery. Currently, there isn't a single, universally standardized treatment protocol for trapezium fractures, which can lead to variations in the duration of cast immobilization or even the decision-making process. In some cases, this duration is determined through shared decision-making with the patient, balancing the desire for early mobility with the need for fracture healing, as highlighted in certain case series.
So there's some flexibility.
There can be. However, based on our current understanding and the results observed, navicular cast or thumb spica immobilization for 4 to 6 weeks is often recommended as the initial conservative treatment. This is particularly pertinent if there's only an avulsion at the CMC1 joint, indicating a less complex injury where the primary concern is ligamentous healing or reattachment of a small bone fragment. The primary goal of immobilization is to allow for bony union while effectively managing pain and preventing further displacement that could lead to malunion or articular incongruity.
That's a clear outline for non-operative care. But when do we know that conservative treatment simply isn't enough and surgical intervention becomes not just an option, but a necessity? What are the specific techniques orthopedic surgeons then employ to address these complex injuries?
Okay, so operative treatment becomes necessary for a few key indications. Primarily when we encounter displaced body fractures, especially in young, active individuals who have high functional demands on their hands. It's also indicated when there's an inability to achieve an accurate closed reduction, meaning we can't realign the bone fragments sufficiently without opening the skin, or if the residual articular step-off is too high.
How much displacement warrants surgery?
Generally, displacement greater than 2 millimeters is considered significant. Maintaining articular congruence is paramount in these intra-articular fractures to prevent long-term complications like post-traumatic osteoarthritis we discussed earlier. Even a small step-off can create abnormal loading patterns across the joint, leading to accelerated cartilage wear. So anatomical reduction is the goal. For symptomatic type 2 avulsion fractures of the trapezial ridge, early operative excision might be considered due to their higher risk of developing asymptomatic non-union, which can cause persistent pain and clicking.
Right. And what surgical techniques are available?
Well, several surgical techniques have been successfully reported, each tailored to the specific fracture pattern and patient needs. Open reduction and internal fixation, or ORI-OFF, is a common and highly effective approach for displaced fractures. This typically involves making an incision to directly visualize the fracture and then anatomically realigning the fragments.
And how are the fragments fixed?
Fixation can be achieved with headless compression screws, which are excellent for providing stable compression across the fracture fragments and can be buried beneath the cartilage surface. Or we might use mini fragmentation screws, which are smaller but still provide good stability. Good results have also been described with K-wire fixation, particularly for less complex patterns or sometimes as a temporary measure before definitive screw fixation.
Can you give an example?
Certainly. For instance, a notable case report detailed a 19-year-old female who sustained a vertical intra-articular trapezium fracture in a motor vehicle accident. This was successfully treated with open reduction and Herbert screw fixation, leading to excellent functional outcomes. Showcasing the efficacy of this approach in appropriate cases where anatomical reduction and stable fixation are achieved.
So ORIF is common. Are there other options?
Yes, beyond ORIF, other techniques are employed depending on the specific clinical scenario. Fragment excision is an option specifically for symptomatic trapezial ridge fractures, especially for those smaller avulsion fragments that don't heal well and cause ongoing pain or impingement. Trapeziectomy, which involves removing the trapezium bone entirely, is generally reserved for lower demand patients or those who present with pre-existing painful CMC joint arthritis or significant degenerative changes. It effectively removes the source of arthritic pain.
Removing the whole bone.
Yes, it can be combined with interposition arthroplasty, using a tendon graft to create a cushion where the bone was. For highly comminuted fractures in high-demand patients where anatomical reconstruction might be challenging or result in a poor articular surface, primary arthrodesis, effectively fusing the joint, may be an option.
Fusion. Okay.
This achieves absolute stability and provides a strong, painless thumb, albeit at the cost of motion at that specific joint. Lastly, external fixation can be a valuable tool for complex, comminuted fractures, particularly when adequate articular surface alignment can still be maintained. It provides stability while allowing for soft tissue healing, or sometimes as a temporary measure.
And the surgical approach itself, does that vary?
Yes, the choice of surgical approach is also dictated by the fracture pattern and surgeon preference. A dorsal approach can be taken, either carefully dissecting between the extensor pollicis longus, EPL, and extensor pollicis brevis, EBB tendons, or by retracting them, followed by a longitudinal capsulotomy to access the fracture. This approach offers good visualization for many body fractures. The Wagner approach, with an incision made at the glabrous border of the hand, is often preferred for sagittally oriented fractures, offering excellent exposure to the articular surface. A volar approach, on the other hand, is typically used specifically for the excision of trapezial ridge fragments, allowing direct access to that palmar projection.
And what about non-union rates after surgery? Are they high?
While the non-union rate after operative treatment of trapezium fractures is not as well defined as for some other carpal fractures due to their relative rarity, the rich vascularity of the trapezium strongly suggests that the non-union rate will be very small. It's generally expected to heal well if fixed appropriately. Indeed, studies have consistently reported excellent results with good restoration of thumb and wrist motion and, critically, pinch function following surgical treatment. This underscores the importance of accurate diagnosis and appropriate, tailored intervention. The immediate postoperative care often involves a short period of immobilization, followed by early motion as tolerated, guided by the stability of the fixation.
Once a trapezium fracture is treated, whether conservatively or surgically, the immediate post-op period transitions into what can be a lengthy rehabilitation journey. Professor, what does that journey look like for patients striving to regain full function? And what are the specific challenges they face? Are there particular exercises or early red flags in the rehab phase that orthopedic professionals should be particularly attuned to?
Yes, rehabilitation is an absolutely critical phase for achieving successful recovery and optimal long-term outcomes after a trapezium fracture. It's often where the real functional gains are made, or, unfortunately, lost if not managed properly. During the initial immobilization period, typically 4 to 6 weeks, depending on stability and healing when the hand is in a cast or orthosis, patients are strongly advised to maintain motion in their other digits that are not immobilized, as well as their elbow and shoulder.
Keep everything else moving.
Precisely. This proactive approach is vital. It helps prevent widespread stiffness from setting in, promotes circulation throughout the limb, and maintains muscle tone in unaffected areas. Simple, but very important. Once the cast is removed, the focus of rehabilitation shifts significantly to a gradual, restorative motion protocol. This phase typically starts with passive and active assisted range of motion, progressing to active range of motion.
What are the main challenges patients face then?
The primary challenges patients face at this stage are often persistent stiffness, particularly in the CMC joint, pain with movement, and a loss of fine motor control and dexterity. Getting that movement back smoothly can be tough. We begin with basic range of motion exercises for the wrist, fingers, and forearm. Patients should be diligently encouraged to perform specific exercises. For the wrist, this includes bending it forward, flexion, and backward extension, and moving it side to side, radial and ulnar deviation, as if waving. For the fingers, simple actions like making a full fist and then fully stretching the fingers out are beneficial for restoring intrinsic muscle and tendon glide. Squeezing a soft sponge or a stress ball is an effective way to introduce light grip activation without excessive strain early on.
And specifically for the thumb.
Crucially for thumb function, practicing touching their thumb to each fingertip, gradually trying to reach further down each finger, helps restore opposition and dexterity. The rationale here is to sequentially activate the muscles responsible for this complex thumb movement. Forearm pronation and supination, which involves lifting the hand over from palm down to palm up and vice versa, is also incorporated to ensure full forearm rotation. Finally, bending and straightening the elbow helps maintain proximal joint mobility, preventing compensatory movements.
Are there red flags we should watch for?
Yes, a key red flag early on in this phase is persistent, unremitting pain with basic pain-free movements, or a failure to achieve expected range of motion milestones despite consistent effort. This could hint at ongoing instability, an unrecognized articular incongruity, or perhaps a developing nerve issue that wasn't fully addressed. These require immediate reevaluation. Don't ignore persistent pain or lack of progress. Pain management is also a large and integral part of this phase. Patients may utilize heat or ice packs, anti-inflammatory medications, or other prescribed pain relief to help them comfortably engage with their exercises.
Working with a therapist is important then.
Absolutely crucial. It is absolutely crucial for patients to consult a physiotherapist or their orthopedic surgeon if they experience any problems with these exercises, or if they encounter persistent pain, as this might indicate a need to adjust the protocol or investigate further. A skilled hand therapist will guide the progression, moving from passive to active assisted exercises, then to lightly resistive exercises using therapy, resistance bands, or specific hand grippers, followed by progressive strengthening exercises for the entire hand and wrist. They'll also focus on desensitization and scar management for surgical cases.
And how long does recovery typically take?
For more complex procedures, such as a trapeziectomy or arthrodesis, full functional recovery can be a longer journey, sometimes taking up to 6 months or even longer to regain optimal strength and dexterity. It requires significant patience and consistent effort from the patient. Occupational therapy can be particularly helpful in guiding patients back to specific functional tasks.
That's an incredibly detailed roadmap for recovery. But despite appropriate and diligent treatment, what are the potential complications or long-term challenges that orthopedic professionals and their patients should be acutely aware of after a trapezium fracture?
Yes, this raises an important point, as diligent treatment doesn't always guarantee a completely smooth course. Despite appropriate treatment, several complications can indeed arise following a trapezium fracture, and we must counsel our patients thoroughly on these possibilities. Non-union, while rare for the main trapezium body due to its excellent vascularity as we discussed, is a higher risk for type 2 trapezial ridge avulsion fractures.
Why is that?
Primarily because these are small, often avulsed fragments with potentially less robust blood supply, and can be subjected to ongoing distraction forces from the transverse carpal ligament. This is an important distinction, and symptomatic non-union of the ridge can cause chronic localized pain. Carpometacarpal joint instability is another significant potential issue, particularly when there's been associated ligamentous damage alongside the fracture itself. Clinically, this can manifest as pain, clicking, or a feeling of weakness and giving way at the base of the thumb during pinch or grip activities. If severe, it can lead to chronic functional impairment.
And the big one, arthritis.
Indeed. One of the most significant long-term concerns, and perhaps the most debilitating for patients, is the development of post-traumatic osteoarthritis. Intra-articular fractures, especially those with any residual step-off, even a small incongruity of a millimeter or two can significantly increase the risk of developing osteoarthritis at both the CMC joint and the adjacent scaphotrapezium joint. It's a sobering fact, revealed in some follow-up studies, that even after early diagnosis and what appears to be successful initial treatment, up to 45% of patients may ultimately develop osteoarthritis in these joints within 5 to 10 years.
45%, that's very high.
It is. This complication must be thoroughly explained to patients during their counseling, emphasizing that while we strive for anatomical reduction, the joint has experienced significant trauma. Early signs can include pain with activity, particularly gripping, stiffness, and crepitus.
And if osteoarthritis develops?
If symptomatic post-traumatic osteoarthritis does develop, a delayed trapeziectomy can be an option for treatment, aiming to relieve pain and restore some function by removing the diseased joint. Other potential complications include CMC joint stiffness, which can be associated with a contracture of the first web space, significantly limiting the thumb's ability to abduct and oppose, thus impacting grasp. We also see rare instances of carpal tunnel syndrome due to swelling or altered carpal canal mechanics, flexor carpi radialis tendinopathy with late rupture if the tendon has been traumatized or irritates the fracture site, and more generally a painful loss of pinch strength and overall hand function.
So vigilance is key long-term.
Absolutely. These are all compelling reasons why diligent follow-up, attentive monitoring for these subtle complications, and comprehensive patient-centered rehabilitation are absolutely vital throughout the patient's recovery journey, often extending far beyond the initial healing phase. #outro.
This exploration has truly illuminated the nuances of trapezium fractures, from their often missed initial diagnosis to the critical importance of tailored treatment strategies and comprehensive rehabilitation. The trapezium, despite its small size, really demands our meticulous attention to preserve the intricate and essential function of the hand.
Indeed. The journey from injury to full recovery is complex. And for us as orthopedic professionals, the ongoing debate around standardized protocols and, importantly, the need for heightened awareness in the emergency department remain key challenges. Our understanding continues to evolve, pushing us to strive for ever better outcomes for our patients, recognizing that a healthy hand is paramount to independence and quality of life.
If you found this discussion valuable, please do consider rating and sharing Deep Dive Ortho with your colleagues. It helps us reach more orthopedic professionals like you. Considering the subtle presentations and significant long-term implications we've discussed, how might a universal screening protocol for thumb-based pain evolve to prevent missed trapezium fractures and preserve hand function for generations to come? This has been Deep Dive Ortho. Thank you for joining us.